Is that on? Sorry about that. This is data from Lucas when he was in Toronto, showing the tidal volume along with compliance. You know, I mean, it's not a large number of patients, but still shows a relationship there, I think, with compliance. So I think there's a number of issues. First of all, any questions from the audience? Let me start. Okay, there are. But when we get the microphones there, I have a question about titration, because this came up a number of times. And I think it's important because one of the questions I think that I heard last night at the dinner was, well, how do you set the gain? And we talked about the titration, and Lucas gave the titration curve, and then John said it's very difficult. So can you two guys fight it out? Is it easy? Is it difficult?
I don't think we have to fight it out, because I think there's a physiological rationale that's there indeed. But I think for a physician that's not really doing it every day and working with it in research, it's difficult with the tools you have. So I think it's physiological good to do a titration curve, but it's practically difficult.
Well, absolutely, I agree. I mean, at the time when we started to fiddle around with the Nava level, we had no idea what Nava level would be appropriate for first for the animals and then for the patients. That's how the whole titration procedure actually developed. But I agree, it's not very practical for clinical daily clinical practice. So it takes too long. It's worrisome, and we need to improve that. And I think there are some thoughts. Maybe Krista can comment on that, how to actually implement an automatic titration kind of procedure into the ventilator. And what comes in addition is the graphic interface of the ventilator as it stands today is not very helpful to actually perform it. So we always have to work around it. So I agree with you, it's not very useful for daily practice. But what we learned from it, and I think that's important, is the physiology. So the interaction between the patient and the ventilator with Nava, that's what we learned from it. And I think that's really helpful to understand how the patient behaves on Nava.
Any other panelists as well want to address how they set the Nava level?
We have ended up in our unit to a very simple practice. We have found out that 1.0 is a good guess to start from. We did it more complicated initially, but now we set the Nava level at the beginning to 1.0 and adjust according to Edimax, which we keep between 5 and 10 mostly, or up to 15.
Anyone else? I saw Leo had his hand up. I think he wants to address that, and then we'll give this to here. Leo, come on up here.
Hey, Lucas, do you know anything about the dynamics of your titration curve? I mean, if I do it at 8 o'clock in the morning, would it be the same at 8 o'clock at night or the next day? I mean, if you use it in clinical practice, how often are you going to do this titration curve?
Well, we never realized any dependency on the daytime. So we performed many of these titrations for research purposes in the morning, in the afternoon, during night even. So there was no dependence on any daytime. In terms of how many times you would have to repeat it if you want to use it, it's just in the study I presented yesterday where we ventilated patients over 72 hours and performed a daily titration procedure. It turned out that what we termed the adequate Nava level stayed the same over the 72 hours. So probably you don't have to do it very often, I would guess. But that's all we have. So we titrated them for 4 times over the 72-hour period, and the level stayed the same over time.
Lucas, the curve is actually quite flat there, so you could, to try and pick the point, you could be off a fair bit. It probably doesn't matter. Like, what's the difference if you're 1.8 or 2.2 or 2? I think it probably makes virtually no difference clinically.
You're right. That's a good comment. I think as long as you stay in the plateau of the response, you're fine. You're fine off. That's okay. I wouldn't want to stay in the steep part of the curve, and that's probably what the automatic titration kind of thing depends on. So maybe Krista wants to tell anything about that. If they reduce the level and just see what the patient's response would be, and then take it from there.
How about that, Christer, there? You've been waiting.
Yeah, I have a question associated with this as well, because Hans said that the patient started to increase the tidal volume. And I see very often that if the patient tries to start to increase the tidal volume and the EDI increases, people tend to take down the Nava level or the gain. And I'm not sure that this is the proper reaction. In these situations, maybe you should increase the gain instead, in order to decrease the distress of the patient, because it might be a sign of distress. And I would like to hear your reaction. How do you do this in this situation?
Sorry? Who wants to take that one? Go ahead.
I'm not certain that I'm really comfortable to answer that question, because it's difficult. But I think it depends a lot on the phase of the disease where you are. If the patient is sick and the pressure is high, it's different as compared to if you're in the winning phase. So I think there's no one good solution. It depends on, I think it's in clinical practice, I think the very important thing I would like to insist in accordance with one Lisa comments, it's critically important to look at the trends many times a day, because you can see how the patient is going, if he's improving or worsening. And I think you have to take in consideration all the trends of the respiratory rate, of the EADI and the pressure, to be able to know if you have to increase or decreasing the Nava level.
I mean, if you just look at this graph here, Christer, potentially, this is different patients. Patients' compliance get much better. They may have a larger tidal volume.
Yes, but distress.
That's what I mean. I don't think there's a single answer based on this. Yeah. Yeah. And then there was a question, I think, there after? Okay.
I think that, as Lucas pointed out, that the titration of Nava was actually our first attempts to try to understand what Nava does when you increase it. That was the first part. I think today, first we look at the literature. I think you find that in all papers that has been published with Nava, short-term, long-term, whatever, people have set Nava level at least in 4 or 5 different ways, some homemade, some recommended by Maquet, some recommended by us. And funny enough, tidal volumes are equal or lower, pressures are equal or lower, oxygenation is equal or better. So it doesn't seem really where you put it, because everyone seems to get it up on that plateau. So what you discuss really is how much do you want to unload the patient? That is really the issue. I mean, I think all of you would put them up on that plateau immediately. And I think to know that you are on the plateau, the easiest way to do that when you are on the plateau is if you increase the Nava level by 50% and you see that you get like 50% increase in pressure, well, you go from, say, 10 and you increase 50%, you should get 15. But if you get 11 or 12, you know that you're well on the plateau. If you want to go the other way, you just reverse the math. It's kind of easy to work with doubles or half or 50% increases and this kind of thing. Simple math can do it at the bedside very quickly, and just one move, and it happens immediately. So after a few minutes or after a minute, you would see if you reach that pressure that you expected, or if they stay at the pressure where they were, then, well, then they choose that level.
There's a question in the second row. Any other questions, by the way? Okay.
Yes, thank you very much for a great session. And I have a question. Based on our experience with premature babies, we see kind of 2 populations of patients. Those that we start on Nava from the beginning, and they are fairly easy to start with Nava, and ventilation is no problem. And then there is a second population of infants who are on different mode of ventilation, and we start Nava on them. And then we see really period of time, sometimes around 15 minutes or even longer, until we see EDI signal. The catheter is placed correctly, but it seems like the diaphragm is misused during the initial phase of ventilation with other mode, or fatigued, or however we can find it in the literature. And I'd like to know if you've seen similar problems and how you solve them. Because Dr. Lehtinen shown that you just set up 2-second apnea alarm. That would be for us almost impractical then to foresee in the Nava, because then we would have Nava PS switched on automatically. And the last question is that in your presentation you've shown very low tidal volumes on the screens. They were like ranged between 1 ml to 2 ml. So are they really that low, or it's just the matter of measurement?
Yeah, yes, first, if we have patients with no eddy signal, I have seen few patients where it's a big problem, but usually they have periods of no respiratory effort. That's typical for preterm infants. And the smallest ones, they have it more, like the one I presented, and in those cases, we have found that this short apnea time works. The ventilator comes in before we see desaturation and bradycardia. As I showed those trends, it can be a short period of time when we need the backup ventilation, and then it can be 10 hours without backup ventilation. The babies are that kind of labile all the time. I don't know if I'm at all answering your question, but
the 2 seconds is a very short period of time. You cannot even see the bradycardia or desaturation within 2 seconds. If the
exactly,
baby...
that's the point. I don't want to have bradycardia or desaturation. But when we have longer apnea time, the patients get them, and then they will be switched to SIMV because they have desaturations and bradycardias. Now we can keep them on Nava 90% of the time, and the times they don't breathe, the ventilator comes and supports.
And I think that the period of EADI, or of silence in EADI you observe, are probably present in conventional ventilation, but much less in Nava. And Maria described it in her paper in premature babies also. And we observed routinely that if the patient is in conventional ventilation, frequently you can think that he is not a good candidate to Nava because he has no EDI, but you just have to decrease your assist and the EADI will come. And sometimes it takes a few minutes. It's true.
Question over here?
There was another question, and I answered.
Oh, okay, you want to?
There was the question of tidal volume. We use quite small ET tubes, and I think there is leakage then, and we don't get reliable numbers from expiration.
Measurement error.
May I have a short comment on this? Because for adults, we had the same problem. For our patients with severe capillary leak in the beginning of the ARDS, we also use high-frequency oscillatory ventilation, and I had the problem several times. If you put them from to the normal ventilator, then I got no signal for 2 or 3 days. And my interpretation was that this is due to the ventilator-induced diaphragmatic dysfunction because of the highly controlled mechanical ventilation without breathing, with relaxation, and. But I observed it, I would say, 4 or 5 times.
I just would like to add just a little bit to the 2 remarks by the 2 Christers here in the room, just previously in a situation where you see that the EDI is going up and a user might think how to turn the Nava level knob. I think it needs to be clear that then actually if you would like to go down with the Nava level, that you put more load on the patient, and that even further increase of the EDI signal is, let's say, in most of the situations foreseeable. So from that perspective, if anybody should do, let's say, a conscious decision in that sense, and I think that refers directly what Christer right said. So it's a matter of unloading, and if somebody, let's say, feels not comfortable with that EDI level and he wants to bring the EDI, with the EDI signal, he wants to bring that down, actually then he needs to do that, what Christer just recommended, to turn the Nava level up.
Theo, and then a question at the back, and then we'll have to finish up.
Just a very small comment on, if you don't see an EDI, it can't be fatigue, because in fatigue you have a high EDI and no pressure development, and it can neither be ventilator-induced diaphragmatic dysfunction, because in ventilator-induced diaphragmatic dysfunction you have a problem in the contractile machinery, not in the signal coming from the brain to the muscle. So you have EDI. If you don't have EDI, it is either heavy sedation or other problem, not a real problem of ventilation, ventilator-induced diaphragmatic dysfunction.
Theo, what about central fatigue?
Yeah, Adrien Rosé described at least one case of fatigue where the EDI had decreased when the patient was in really strong distress.
Well, if you previously keep a patient on controlled mechanical ventilation, how you can develop fatigue? Central fatigue has been described when you have significant duration of loaded breathing, and to protect the muscles, probably. The respiratory center downregulates its output. It could be apnea of central apnea, not central fatigue. This is my interpretation.
If you can separate them. Lisa.
I just wonder if one factor is the use of medication during the previous ventilation modes, and that depresses the breathing. I don't know, that might be one factor.
Yeah. Question at the end? Doctor?
Hi. I have a question regarding the Nava level titration, and this deals with the optimal pressure level. How high of pressure are you willing to accept in order to reach a point where the EDI begins to decrease as you increase the Nava level? Offloading. Because it seems to be a question that I'm asked oftentimes in the clinical settings. Sometimes 30 is not enough. But if you go up to a pressure of 40, then all of a sudden you have the EDI beginning to go down, and then you're out of that zone. Again, any advice on that?
Lucas.
For the titration procedure, we are normally very liberal with the upper pressure limits. We just set it to 50 or something. So you have to be liberal because we cut off the peak pressure, which are not really relevant after all. Then you might get a fake titration curve, which is not representing physiology. So you probably have to choose a fairly high limit of pressures, peak pressures.
Yes, and I think that's the dilemma, because in clinical practice, generally we're taught peak pressures above 35, don't do that. Plateau pressures above 30, don't do that. But if we're talking about trying to titrate the Nava level to offload a patient, there are times when you may have to exceed that in order to reach your target to offload the patient. And it's a momentary increase. So I don't see anything written in the literature regarding how high is too high.
Well, some questions that can't be answered definitively.
But still, it's a good point. It's a valid point. But when you look at all the study we've done so far, you always end up with lower mean inspiratory pressures above PEEP as compared with whatever was there before. So by the end of the day, you're safe. It's never a problem of high mean inspiratory airway pressures, which are relevant for distension of the lung.
You basically said this is transitory. It's like a recruitment maneuver. So, and it's also the peak pressure. So you've got the pressure, the flow. So going to 50 for a breath or two, not a problem.
The thing is, again, talking about that in the ICU with some of the physicians.
Just one breath.
There you are. And it's not the plateau pressure.
No.
It's something we have to keep in mind.